Hi, everyone. Thank you for joining us tonight for this webinar. We're just going to wait a couple minutes for anyone who might be currently logging in. All right, it looks like we have a really good number of attendees logged in. Thank you again for joining us tonight for the webinar. My name is Kristen Cachetta. I'm the nurse practitioner with Dr. Albert Fenoy here at Northwell Health. Tonight's webinar will focus on treatment options for tremor, including both deep brain stimulation and high-intensity focused ultrasound. Dr. Fenoy is the director of functional neurosurgery for Northwell Health. He does deep brain stimulation and high intensity focused ultrasound, amongst other procedures, out of North Shore University Hospital here on Long Island, New York. We have the first and only focused ultrasound center on Long Island currently. Dr. Fenoy is a world-renowned neurosurgeon specializing in procedures that help improve the quality of life and ability to perform ADLs for patients for a variety of neurological and psychological conditions, including Parkinson's disease, essential tremor, dystonia, treatment-resistant depression, and chronic pain. After obtaining his medical degree from Stony Brook School of Medicine, he completed his residency at the University of Iowa, followed by fellowship training at CHU Grenoble in France. He began his career at the University of Texas Science Center at Houston, where he worked for 15 years prior to coming to North Shore University Hospital almost 3 years ago. He has implanted about 900 patients with deep brain stimulators and has done over 70 high-intensity focused ultrasound cases since our focused ultrasound center opened in April of 2023. All this to say he's a seasoned professional at these things. In addition to Dr. Fenoy's presentation tonight, we have a special guest joining us. We are so thankful to have one of our DBS patients, Annette, here tonight on the webinar with us. So Annette, thank you for being here. It's super helpful as a patient to hear stories of others suffering with the same disease process and have the opportunity to directly ask them questions. At the end of the presentation, Annette will share her story and we'll open the floor to questions. Although we will be answering all the questions at the end of the webinar, please feel free to use the Q&A button at the bottom of the screen at any point if any questions arise. We will go through them at the end, and Dr. Fenoy and Annette will answer them. If you would like one of them to answer it, please indicate who you would like to field your question to. Dr. Fenoy, take it away.
Hey, thanks so much for that great introduction, Kristen. Hello, everybody. Thanks so much for having me. We're going to talk today about tremor and how we can treat it using DBS or deep brain stimulation or high intensity focused ultrasound or HiFu, and the when, why, and hows about it. So in terms of our agenda, we're going to talk about essential tremor and the target that we use for either of the procedures. We're going to talk about deep brain stimulation, what it is, when do we use it for the right time, and why we use it. Some examples of the procedure, as well as the high intensity focused ultrasound procedure and efficacy. And like Kristen said, we're going to chat with our star patient, Annette, after we finish. So let's talk about procedures. So tremor has been around for a long time, and we've been treating tremor for a long time, decades, in fact. And so back in the day, long before I was born, not really that far, but long enough, in 1950, we started doing surgeries for tremor, and we started looking at the same target area we use, realizing that there's a tremor circuit we need to modulate or destroy. And this was through surgery, where we put an electrode, or actually a probe, into the brain, and we burned an area. And it was effective, but it wasn't so super guided, and there are better ways to do that now. So long story, cut to the chase. Right now, we have two procedures after years and years of modifications that we currently use today for treatment of essential tremor, among other diseases. One procedure is surgery called deep brain stimulation. This involves surgery where we implant an electrode into a target area in the brain. The target we'll talk about in a little bit is the ventral intermediate nucleus of the thalamus. And by putting this electrode in there and using high frequency stimulation, we can cause a functional block of this circuit. This leads to immediate tremor reduction. It is not a permanent lesion. We can actually adjust it over time, which is important because tremor is a progressive disease. This does require a surgical implantation of electrodes that connect to wires into a battery that we put in the chest. As with all surgeries, there is risk of infection and bleeding, and this requires a follow-up and adjustments as over time, as you would need for any type of device, but it is extremely useful. The other procedure that is used nowadays very frequently, as its advent in 2016 and FDA approval, is high-intensity focused ultrasound. This is a non-surgical technique where we focus ultrasound beams through the skull to create a lesion at that same target area. Now here we actually are destroying the tissue, but not through surgery. We can cause an immediate effect in tremor using MR guidance. This is very favorable, but because this is a lesion, we can't adjust it over time, but very efficacious. So we'll talk about these two procedures and when and why a patient may want to choose one versus the other. So let's talk about essential tremor. This is a big disease. In fact, it's the most common movement disorder in America. It affects approximately 10 million Americans. Up to 50% of patients do not get satisfactory relief from medications, or the medications cause them to have intolerable side effects. DBS has been around for over 30 years, 20 years in this country over that. But because it is brain surgery, it's not super exciting. So there's other options that have been offered to patients, such as focused ultrasound. And that has certainly led to its adoption in the past 7 years. Essential tremor, as we said, is very debilitating, and it affects many people. And for this reason, we are trying to help patients. So here is a little video showing how a patient with tremor has difficulty with performing things, simple tasks such as pouring a glass of water, writing, eating, simple things, tying shoes. These are problems. So before we consider types of treatments, we consider other types of interventions, rather. There are certain types of treatments that are less invasive. One of the first things that a patient may try actually would be medication. Medications are advisable in any type of disease because they're less invasive and obviously could potentially help you very well. Initially, patients typically start with a medication called propranolol, which is a beta blocker. It reduces the heart rate, but has the effect of suppressing tremor sufficiently. If that doesn't work, typically another type of medication is used called primidone, which is an anti-seizure medicine. And in fact, there's plenty of other anti-seizure medicines that work in a similar way, just to suppress nervous system activity and therefore can suppress the tremor. Unfortunately, as we have to increase the dosage or increase the number of medications needed to suppress the tremor, that can also lead to some type of side effects, such as drowsiness and sedation, or even nausea. And so they're not perfect. And as tremor progresses, this is something that needs to be fixed. There are also wearable devices that can be used, which kind of like a weighted fork, weighted instruments. These are things, or wearable neurostimulator. It's kind of like a little bracelet device. They have somewhat of an effect, but they're not really doing anything to have a long-term improvement. So therefore, after we've tried these non-invasive type of therapies, we consider the invasive therapies such as deep brain stimulation or focused ultrasound. So the area that we're trying to lesion or target for stimulation in the brain is the same. It's called the ventral intermediate nucleus of the thalamus. It plays a critical role controlling the flow of information that comes from the back of the brain called the cerebellum up through to the motor cortex. And so this pathway we are intercepting here by placing either a lesion or an electrode, and the electrode is causing a functional lesion, a kind of a block. So we basically want to cause a roadblock in this pathway. And by causing a roadblock in that pathway, we can improve tremor. Um, when this started in 1954, the thalamotomies was where we burned this area through that surgical probe we placed to create the lesion. We've since evolved to either causing that lesion through focused ultrasound or using deep brain stimulation by putting an electrode there instead of that probe. If we want to see this pathway, this is kind of what it looks like. We use some specific types of fancy MRI guidance looking at tractography. You can actually picture this tract in the brain. And so here it comes in the back of the brain going up to the motor cortex, but we can actually visualize it. And within that pathway, we're creating this roadblock. So just think about creating a roadblock within this pathway, how we're trying to fix the problem. Again, this is a paper that I wrote, but basically showing how we can look at our tracts in many different ways. And by placing an electrode or a lesion there, we can block this and we can specifically target this tract, which helps improve efficacy or how well we can control that tremor. So let's talk now about deep brain stimulation. Deep brain stimulation, as I said, is placing an electrode into this target area. When do we consider DBS for essential tremor? Well, the tremor is not being helped by medication. We call that medication refractory tremor. So we've tried medications, but because the medications are not sufficient to control the tremor or the side effects are too great, we stop. So my side effects would be intolerable. This is something that obviously a patient we don't want to continue using because that causes too much of a unpleasantness. So surgery would be a good alternative. There is no age limit for deep brain stimulation. We look at your functionality and ability to have this surgery, kind of your cognitive profile. Can you understand the procedure? Do you have if you have a great amount of dementia, then that would be a contraindication. But otherwise, no, there is no age limit for this. And also there's relatively no lower age limit, but typically we do not implant minors for essential tremor. When we really the most important thing is that it's the poor quality of life that leads patients to go towards a intervention such as deep brain stimulation. It's when a patient's quality of life is suffering enough after medications that they need something else because they're having a stigma associated with what they don't want to go out and do things, or it's just something that can be done. And that's something that only a patient can really express, not the provider or anybody else. It's really the patient's own understanding about when they really want to seek help. And this is for either type of procedure. So why consider deep brain stimulation? Well, it's because we want to relieve that motor function, that tremor, when medications are not adequate and when the quality of life is really suffering. It's not a big brain surgery, and that's the problem with why patients have shied away from this, because or I guess patients have a tendency to think that, hey, big brain surgery is gory, gross, bad things are going to happen. Well, this is more of like a small intervention, creating tiny little windows in the brain to specifically target this electrode expertly to modulate the circuit that I talked about that's causing dysfunction. So it's not, all brain surgeries are not the same. Consider this more like a nice, precise intervention. Why deep brain stimulation over a lesion? Well, as I mentioned before, this is a reversible, not permanent procedure. So although we typically don't take out the system, we can if we need to. We are not destroying an area in the brain. We are placing this electrode into this area, and by increasing stimulation through different parameters, we can cause a functional block of this pathway. Because it is stimulation and electrodes, there are many different parameters that we can adjust over time. So I'm not sure if I mentioned, but essential tremor is a benign, degenerative, progressive disease. And as most patients know, that patients will start with tremor, typically start with a small amount of tremor that progresses as they age, and it will progress until you die. Patients will not die of this. This is not going to cause death, but it'll last forever. So we shut off the electricity and the stimulation, the tremor will come back. Well, we can keep on adjusting the stimulation to make sure that we have really good control of that tremor continuously. And that requires an expert placement so that we're not having any type of side effects, which I'll explain in a second. But we have to have the ability to adapt to a changing disease state. So in deep brain stimulation, we have the ability to adapt and adjust the stimulation over time to adapt to that changing disease state. When we create a lesion, we can't do that because that's one static fix at one point in time. So overall, better quality of life is what we afford by deep brain stimulation. Deep brain stimulation plus medication is superior to medications alone. But typically, we try to drop the medications if in tremor, for instance. So stimulation is superior. Why DBS? Again, this has been around for a long time. This is not a new intervention. 1992 is when you got FDA approvals. Nearly 200,000 implants or more worldwide. It's definitely underused considering the amount of patients that have such a disease. So now I'm going to skip. I'm going to bear with me. I'm going to change to another situation here. Just going to show another little clip. Hold on, please. Um, I want to show just a little video on my website that I have, which could be useful for patients. I think you should be able to see it now. So this is a website that I've made, which kind of shows a video of the procedure on the right. You can see that we're in the operating room performing the surgery. This website is very helpful for anyone who's on board. It's just my name, albertfenoymd.com. And there's lots of information here under the menu button, but this just shows an overview of the procedure and how we precisely place this electrode to target. I don't have any videos otherwise from here, so I encourage anyone who wants to look at this video and the website here. There's many different choices under the menu bar of things that a patient can see. So I'm going to go back to the presentation. Okay, now we're back on the presentation. So you just saw the procedure of deep brain stimulation. That's what it looks like in the operating room real time. But basically, an operating room looks like this. We have lots of gadgets, and we all use them so that we can synergistically perform the surgery in the best way possible. Lots of cool gadgets to make sure that we're doing this precisely. First thing we do is we plan the trajectory, and that requires use of fancy computer navigation systems, and that navigation system is then tied to a computer and an output screen where we use that MRI that we obtained of the patient previously before surgery and plan the electrode trajectory. We then draw little tracks in the brain, that track that we're trying to intercept. Well, we can actually draw tracks to see where they're going. And once we draw them, we can see where we want to intercept them in that same target, the ventral intermediate nucleus of the thalamus. That is certainly something that we do ahead of time. Once the patient gets to the operating room, we do not have to shave your head, as Annette can attest to. And we then place a frame on your head. That frame is a stereotactic frame just like this, so we can localize your brain in three-dimensional space and pick out the target coordinates to place the electrode at that target we just mapped out or planned. Once we do that, we will then place you into that this O-arm. This is the three-dimensional imaging device called the O-arm because it looks like an O. And you sit in there and we can image you afterwards. But basically, you're sedated at this time. You are asleep, not intubated, but asleep with sedation going through your vein from the anesthesiologist. And you're going to sit in there while we get you into position. We'll then drape you. We'll make incisions in your scalp. We'll drill holes through your skull. And then we'll put wires into your brain to listen to your cells fire. That lets us know that we're in the right spot. Once we're there, we will then wake you up and we will then stimulate you. So here, this is what we look like with the electrode planted into the target area, connected to wires. We're then going to turn on the stimulation and see how the tremor is improved. And again, this is the website you can go to look more about this. But basically, we will see your tremor. We'll wake you up. I'll come and walk around the drapes. We'll see the tremor, and then we'll see it go away once we apply stimulation. Not only do we want to see good effect, we want to see lack of side effect. Because very close to where we're stimulating, we can cause a tingling sensation or a pulling sensation. We want to make sure that this is in the best location possible for the rest of your life, basically. Although we don't need to apply very high stimulation current initially to control the tremor, like we said, your tremor is going to continue to worsen over time. At whatever rate it is, it will gradually worsen. And so we have the ability to keep on adjusting that stimulation to maintain in that bay. So this is a schematic of what the electrode looks like. Basically, the electrode that we place to target has 4 contacts. The 2 inner ones are segmented into thirds. And then it gives us the ability to directionalize the current. So by creating this current, we're creating this type of virtual lesion, not virtual, but a lesion that a functional block of this area. And by putting it in the right location, we can change the shape of what we actually want to block in that pathway to make sure that we don't create a side effect. So we test and we make sure that it gets to the right depth so that we, again, have all the abilities available. This is a blow up of the electrode, obviously. This is about 1.3 millimeters in diameter, and this spans about 10.5 millimeters in total length. Each contact is 1.5 millimeters long. So that's what the electrode looks like. Once we place everything, we have you go to sleep, we close up, we get this O-arm. This is a three-dimensional imaging to make sure that our electrodes are right where we want them in space. Once we're satisfied, we close up. You go to the recovery room, you stay overnight. Typically, most patients go home the next morning. After you go home, you come back in about 1 to 2 weeks for the second procedure, called the stage 2 procedure, is where we connect the wires we leave underneath your scalp to a battery we put in your chest. That surgery takes about 20 minutes. You're totally asleep for this, and you go home. The first surgery takes about 2 hours plus or minus after we position you and everything. After the second procedure is done, you will then return back to your neurologist where the programming will occur. And that programming is where you'll find the benefits of the surgery right away. That programming will not be what we consider optimal initially. When we apply the electricity to your brain, sometimes your brain has to adapt to that electricity over time. And so you may need some fine tuning typically a couple of times afterwards to make sure that it's in the best state possible. If there are medications that have to be reduced at this time, they're also reduced while we're increasing the stimulation. So this is what the second procedure would look like as a schematic. The electrodes that are connected to extension wires that go behind your ear to the battery that we implant in your chest. That battery can last up to 5 years, but it also depends on the amount of electricity that we have to use to control your stimulation. So we can't, it can last longer, it can last less. Everyone's very different depending on how much they need. Regardless, to change this battery is a very simple procedure done as an outpatient. Basically, it takes 10 minutes to open this incision, take out the old battery, put a new one in. So that's not a big deal. There are also rechargeable versions of batteries that we typically use if the current needs are great. Typically, we don't do that right away because at the initial placement, because we want patients to get used to the device and not have to worry about recharging. But that is an option. So the risks of surgery, there are risks since this is a surgical operation, less than 1% risk of bleeding, hemorrhage, and bilateral lead placement. Again, less than 1% typically in my experience. It usually is, if it does occur, it's usually unlikely to be symptomatic, means that you won't notice it, but it's something that we have to be wary of because it is surgery. That's why we plan very well prior to placing these electrodes. There is a risk of infection, just like any other surgery. It's less than 1% in our hands. It can be much greater elsewhere. Also, because this is a man-made device, this can break, can fracture. The quotes are about 4% in the per electrode worldwide. We have far less than that. I don't. It's fractured due to trauma. That can certainly happen. So of course, be careful. But we want you to live your life and do things. We don't want you to stay at home. We want you to do things. But things can break. We can fix them. Efficacy. The goal of doing DBS is we want to control that tremor. We usually get greater than 90% improvement, which is what our goals are, and we succeed. So just like focused ultrasound, that is our goal as well. All right, we're going to shift gears now and talk about high intensity focused ultrasound. So this is a lot newer, come to the landscape in 2016. So this is a schematic showing in 2017 the use has skyrocketed over the last 8 years. And so that's basically it. So the amount of tremor that's been treated for focused ultrasound has exploded over the last 8 years. What is focused ultrasound? Basically, we are focusing ultrasound beams through your skull using this helmet-shaped transducer, up to 1,024 of those sound waves. They're precisely delivered safely through the skull. There's no incision, there's no surgery. Only where those sound waves converge will the temperature at the target tissue increase. So that's where the lesion occurs. And that lesion size is about the size of a pea. Again, at the ventral intermediate nucleus of the thalamus, the target area that we use for the disease, period, regardless of the intervention. That is the node within the pathway we need to cause that or create that roadblock. Again, so we have a transducer that's placed around you, which we'll show in another schematic. Those sound waves are directed through that with no incisions, only where they meet, we cause the improvement. This is the patient here, one of ours, you could see drawing prior to the intervention. You see the frame is again placed around their head, having a tough time drawing their spiral. And this is our goal of what we want to make better. So that's the situation here. Okay,
During
so
treatment, you will lay down on the
hope you can
treatment
hear
bed
this.
inside the MRI scanner.
Yes, we're going to play it again.
During the treatment, you will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked.
Oh, okay. Well, somehow we jumped past that one. I don't know why this shut off. Let's see if I can play this again here where it ends.
Physician will first apply. Sound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects.
Okay. So that's basically what happens in focused ultrasound. So we'll go through this a little bit more in detail. This occurs at North Shore University Hospital in the MRI department. The new brand new suite, well, as of 2 years ago, is adjacent to One Cohen. That's where we perform this procedure. So just like these video mentioned, we are basically delivering ultrasound beams through the skull to create this lesion. Before we create the lesion, we perform light doses of energy to test the target. Just like in deep brain stimulation, we're testing the efficacy of the electrode before we secure it. Well, here we can give a light dose of energy to see if this target area that we've chosen is going to have an improvement. And so just like the video showed and the picture down below, I will come around and I will make the patient draw spirals or hold a water bottle to assess their degree of improvement of the tremor, as well as to check for side effects. The side effects here, again, would be tingling that they may elicit or have elicited in their fingers or experience on their side of their mouth or on their tongue, or a problem with their speech. If we don't have any side effects and we have good tremor improvement, we will then increase the energy to create the actual lesion. This lesion, again, we're not using any type of surgery. There's nothing implanted. Typically, after this procedure, this lesion is performed, we will get good tremor improvement. We typically do one or more of the lesions, typically 2 or 3, to create a larger roadblock in this tremor pathway to improve efficacy as well as durability. So what happens on the day of the procedure? So unlike DBS, here we have to completely shave a patient's head. And this is necessary so that we can get those ultrasound beams through that skull without interference. And that hair, if there's beautiful hair, well, that can cause a lot of interference. And so we need to uniformly remove it. This is not just here at North Shore University Hospital. This is everywhere in the world. So if you want focused ultrasound, the hair has to go. So we shave the head. Once we shave the head, we put that in that frame that you saw. That's so we can, again, localize your brain 3-dimensional space. Then we do the planning. So we make sure that everything is set up in the X, Y, and Z coordinates. Then the MRI that we obtained previously, we then put you in the transducer, get a small MRI, again, short one. And then we test you, like we draw the spirals, have you hold a water bottle. We do the testing by applying low doses of energy to see an effect. If we're good without side effects, we then create the lesion. If it doesn't completely extinguish the tremor, which it typically doesn't completely, we do one more or another one, as long as the patient decides patient is completely awake during this procedure with no sedation. This is important because the patient has to communicate to me what they're feeling. If they feel any type of tingling or have a voice change or something, I need to know that, preferably before we've created the lesion, so we can change the target slightly and avoid this. If we have you sedated, you can't tell me if there's a problem, and that would be really bad. So we need to have you completely awake for this procedure. We do the treatment, and this treatment, the whole duration of time within the MRI scanner is typically less than an hour and a half. Once we're done, you come out. We will take everything off the transducer, the frame and the plastic membrane. You'll have a glass of water with your new tremor-free hand, as well as a sandwich, and get a short MRI and hit the road. So who is eligible for, oh, wow, we're going fast here. Who's eligible for focused ultrasound? So you need to have a confirmed diagnosis of treatment-resistant or medication refractory essential tremor, or tremor-dominant Parkinson's disease. So in tremor, you need to be 22 years or older. For tremor-dominant Parkinson's disease, you need to be 30 years or older. Because I mentioned you have to be awake and communicate with me. You have to be able to tolerate the procedure without any type of form of sedation. You have to communicate. You have to obviously fit in the MRI scanner, since this whole thing occurs in the MRI scanner. If you can't have an MRI, then you can't have this procedure. So that's that. One of the more important things that we have to also do is make sure that your skull density ratio is higher than a certain limit, and that limit is 0.45, 0.4 typically. Well, the skull density ratio is the screening process that we do. We collect this information from a CT, a CAT scan, and basically it measures the amount of energy that is reflected off your skull. So if you have a low skull density ratio, that means that some of that energy will reflect off the skull, more of it will reflect off, and less will be transmitted into the target area. That means if it's too low, we cannot perform the procedure adequately, meaning we can't create the lesion and we can't get a good tremor improvement. So if your SDR, or skull density ratio, is too low, then we cannot perform the lesion. And so we then would say, after you get the CT, if this is not adequate, we would then push you towards deep brain stimulation or other types of treatments, because unfortunately, we don't have the power to create the lesion. So we definitely look for a skull density ratio greater than 0.4, typically. The CT is one of the first processes that occur. So after you come in consultation with us and you're interested in focused ultrasound, the first step we would have you do is get a head CT to measure your skull density ratio to see if we can continue down this pathway for performing a lesion high intensity focused ultrasound. Why do we do this? Because right there and then on the table, after we perform this lesion, you will have immediate and durable tremor improvement. We're doing this because we want to improve your quality of life, and you will get that if that's why you chose to get an intervention. This is outpatient. You go home the same day. We're not doing surgery, so there's no risk of infection. We're nothing implanted. There's no anesthesia. There are minimal complications. So this little video here shows a patient on the left with tremor, and immediately after the surgery, patient on the right has no tremor, the surgery intervention. And that is something that we see right on the table, but again, magnified when the patient leaves and can actually hold a glass of water and drink it. So it's perfect. It's not perfect, but it's definitely something that's great. This is one of our patients who we could see them having a problem with holding that water bottle with tremor before focused ultrasound. We'll play it again. Pretty tremulousness. And after the treatment, you can see that there's a difference, or actually during the treatment, and this is how we're assessing whether the spot we chose is adequate. This is what the lesion looks like. So this, you can see before treatment on the left and after treatment on the right. This hyperintensity here is the lesion that we've created, the area, that node, that ventral intermediate nucleus of the thalamus, that pathway that we blocked. So that's that there. I guess this jumped away, but I don't know why. This is having a problem jumping. You can speed this up a little bit. This is during the focused ultrasound. We see the improvements, and then afterwards, I believe there's one other little section. There we go. Right after treatment, you can see that his tremor is greatly improved. So very useful. We showed you this picture. So efficacy, this has a mind of its own. So efficacy. So there's been a very small cohort of patients that have been followed for 3 to 5 years. And we aim to get about 90% improvement of tremor initially, which we are pretty decent job doing. Typically, because this is a one shot in time and tremor is a progressive disease, that improvement wanes over time. And that the average of this small cohort of patients, that tremor improvement waned to about 75%, which is still significantly better than what a patient had to start. Right after the procedure, there are some side effects. Typically, because we're creating a lesion in the brain, that lesion is going to have some swelling or edema around it. That will cause a patient to have a little trouble with walking or imbalance. Most patients typically experience some type of imbalance within the first week after the procedure. We give every patient steroids for a week afterwards to help lessen that amount of swelling, but still some patients have it despite steroids. We give every patient a walker to make sure that they're not at risk of falling. Obviously, don't have to use it, but if you have a predisposition to have imbalance prior to the procedure, that imbalance would worsen. But it usually comes back to baseline. How long it lingers, again, is something that we cannot predict. And this is depends on the amount of energy we use, your anatomy, specifically, and again, if you have any type of predisposing balance issue. Similarly, although we probably will not get any type of paresthesia or tingling sensation you experience in your hand the day of the procedure, that swelling could help precipitate or cause some of that swelling after, some of that tingling afterwards, which will help, again, be improved by the steroids, but you may experience that, and that should, again, go away over time, typically within the first few weeks. That may persist a little longer. Headache. Patients, when we're doing the actual lesion, will actually have a headache, which will get better over time. Some patients have it, some patients don't. It's not everybody. At 3 years, there's very minimal side effects that are seen, and typically, like I said, most of the side effects that are experienced are gone within the first month if they're there at all. And the next slide just shows that there was more data over 5 years that has very similar effects. The efficacy is durable in this small cohort that was seen for up to 5 years. The durability, or meaning how long the tremor improvement lasts, is highly variable on any patient. We can't predict that, unfortunately. That depends on your own disease process, your anatomy, how much energy we're needing to apply. So although our goal is to improve your tremor, there's no guarantee in how long that's going to last, but we're going to try our best to help you. Insurance. This is insured, covered in all 50 states by Medicare. There's different plans that have different things. This is becoming a lot more prevalent in the United States. And so that's best, if you have any questions, it's best to ask our office, because everyone's plan may be slightly different. I think I just have one little video here, and
the essential tremor for me has really put a damper on my life. If there's anything I can do on my part, I should do it. I Googled focused ultrasound. If this can help my tremor, by all means, I will do it. I will do it. There's no cutting, there's no stitches. I will be able to live doing the things that I once loved and can do again.
Look, look, like that.
That.
Amazing, right? Let's take you to see your husband. That's fun.
So that's very powerful, and how we can help people. So we're going to move on. So just a quick update of our focused ultrasound program. First in Long Island, we started almost 2 years ago in 23. We have over 70 patients now. And you can see the bottom picture here of the spirals of this is one of our first patients who agreed to have their picture taken. You see how they had trouble with the signature and with their spirals and drawing, and how it greatly improved post-procedure on the right. So really efficacious. This is the slide to show you how to contact us. If you'd like to come see me and see Kristen and talk to us about your tremor and how we can tailor make a treatment plan for you, whether it's deep brain stimulation or focused ultrasound, or if you have questions, there's nothing that we will push you towards. It's purely educational. That's fine too. So this is now where we're going to move on to have our featured guest speaker here just talk with us about her experience with deep brain stimulation. I hope that you have the access to all the things you need here. Annette, please take it away.
Okay. Hi guys, my name is Annette Ray. I am 40 years old, and I think that's kind of important for my story. Um, and I'm also a working professional. I have my own business, my own consulting agency, and in addition to that, I work for a big conglomerate doing in-person sales of financial needs. So I'm constantly meeting with CEOs and CFOs. And on top of all of that, I'm also a mom to a wonderful little 12-year-old, very active boy. I was diagnosed with a tremor at about 20 while I was in college getting a degree in art. And it was very disheartening because it meant that I knew that I could eventually lose my ability to draw. And eventually I did. Um, Over the past 5 years, I stopped being able to write and started depending on my husband more and more for things. And my breaking point was taking my son to an allergist appointment and not being able to fill out paperwork for him. He was 10 at the time, and no child should have to do their parents' responsibilities. So I knew that what my then neurologist had told me where essential tremor was, as Dr. Fenoy said, a forever diagnosis that was progressive. At the time, this particular neurologist told me there was, other than primidone and the other medication, there was nothing else that could be done. I tried both of the medications. They did not work. Like I said, I have a child. I have a high intense job. One of the medications is a beta blocker. It made me feel faint. And the other one gave me just side effects that I did not like. So I just dealt with it and it progressed. And one day I was on, I think, Instagram, and I saw somebody had copied a YouTube video from Dr. Fenoy or something. And I actually found him. I was like, oh, he's in Long Island. I'm in New Jersey. And I called his office. His assistants called me, and I went in, and I actually went in for HiFu, the high frequency intensity ultrasound. And, after much discussion and my needs, my immediate needs to be, you know, to have results right away, we came to the consensus that DBS was the way to go. It wasn't a light decision for me. I definitely left Aisha and Kristen waiting for a long time. Um, so, but I did eventually do it, and I am ecstatic. I was to the point where, like I said, I hadn't written in about 5 years. Um, and I'm always presenting. So doing my makeup was very difficult. There were times, it just seems little, but there were times where you're going to go meet with a multi-billion-dollar company and you just want to look presentable, and it would take me more effort than not. So those were some of the small things that led me to that decision. And, of course, there's my family. Like today, I took my son to the allergist again for a follow-up appointment, and I was able to fill out the paperwork, which was such, like, my son could be a kid. And that was super important to me. So, yeah.
Wow, well, thank you so much. That's a powerful story, Annette. Um, would you now, I know that I kind of asked you this earlier, but I think you have the ability to shut off your device.
Yes.
So is that something you're
Okay.
willing to do?
Let's see. But I'm following the instructions.
Great. So Annette is now Bluetoothing. Every patient with deep brain stimulation is given a patient programmer. And so they have the ability to turn on and off their device or make adjustments when they're at home if they're away from the neurologist. Like Annette lives in New Jersey, and a neurologist that is following her for deep brain stimulation is part of our group, is in Great Neck. And so without having to come back and forth to the office, we gave her certain parameters, guidelines or sets that she could increase her stimulation at home under guidance if she'd like, or just if she wants to play around, she could increase her stimulation. So that's what the patient programmer is. It has the ability to shut it off though, if for any reason you want to shut it off, and turn it back on. So that's what Annette is just doing by Bluetoothing into her battery, which is in her right chest.
So now my stimulation is off. Um, my entire body is shaking. My head is shaking. My upper body is shaking. My hands. This is so bad. But yeah. So
And so this is the kind of the feeling that you had for years prior to having the stimulation on.
it's exhausting. I think one of the biggest things is I never noticed how tiring it was, and then having this turned on and feeling still. Like the first time I had it turned off was last week because I haven't wanted to turn it off because life not shaking is amazing. Um, you know, there's also a lot of little things that I think more than just career-wise and parent-wise every day when you get pulled over by a cop and they ask you, why are you so nervous? It's like, I'm not nervous. I have a tremor, or just meeting people in general, or even holding a cosmopolitan and a high glass. I couldn't do that. I would always have to order cocktails in, a flat glass and have to, it was just an ordeal. Like you can't just live the little things that you don't notice, and now that's gone.
Wow, that's a lot. Well, thank you. We can have you turn back on your stimulator and probably make you feel better.
It's going. And it's on. I have a little bit on my right hand still because I've only been to 2 sessions, but that's pretty
Great.
impressive.
Well, we're so happy for you, Annette, and so thank you so much for sharing your story with us and whoever else is listening here. I guess thank you, everyone who attended, and so we're ready for questions now, and I'll hand it back over to Kristen.
Thank you so much, Annette, for sharing your story, and Dr. Fenoy for that awesome presentation. We have some questions here about second side treatment for HiFu. So let's just start with, when are you eligible for treating the second side?
Great question. Sorry, I probably glossed over that. So you can have a treatment. This is a treatment for a unilateral disease. We only create a lesion on one side of the brain. So if we want your dominant hand and you're right-handed treated, we would create a lesion on your left side of your brain. For FDA rules, we have to wait 9 months after the first side to do the second side. That may change over time, but right now it's 9 months. So we cannot perform the second side before 9 months. I also maybe just want to clarify that our goals of focused ultrasound treatment are to help tremor in your hand only. So our goals, if we want to help tremor in your hands, we do it on the one side and then again on the other side. There's no guarantee if a patient has head tremor that we may improve your head tremor. Now, we could have some tremor improvement, but that is not a guarantee. So if a patient has head tremor as one of their priorities that they want addressed, focused ultrasound would not be the modality of treatment.
Okay. One of the questions is, how many second side HiFu cases have you done? I think we're between about 5 and 10 of them, just because of when patients become eligible for that.
Yeah,
What do you think?
I'd say it might be more than 10. Honestly, I don't know.
It's somewhere around 10
Yeah,
probably,
around
just
10.
because, I mean, our center opened in April of 2023. by the time patients become eligible 9 months later. You have to have tremor on both sides to want to do the other side. So I think it's somewhere around 10
Yeah,
probably.
I would say around 10.
What tests are done prior to treating the second side with HiFu?
Tests. So if we treated your first side, we would have gotten MRI and a CAT scan. Typically, we just have you check your tremor. So we grade your tremor and how much it is. We also check to see how much ataxia or imbalance you have. Not just we do it, but we also send you to the nurse practitioner for the movement disorder neurology team to just do a little bit more formalized testing. Aside from that, if you um, have if you're on a blood thinner, we will need to stop the blood thinner. Although this isn't surgery, we could potentially cause a bleeding, which has never happened, but we don't want that to happen. So if you need to be off your blood thinner, then we need to get some type of clearance for that.
Okay, good. This is pertains probably to any HiFu treatment, but what is the wait like from when they see you in the office to when they can get the procedure for either the first or second side?
Well, our wait time to see us is very minimal. I'd say 1 to 2 weeks should be able to come see us. Once that's done, the first thing we would have you do is on your own, if you're really interested in getting focused ultrasound, is to get the head CT. That would be the first thing to do so that we can make sure that you're eligible for the procedure. Once that is done, then we'd have you go see the nurse practitioner for neurology, typically within a month, I'd say.
Okay. Can the surgery do anything for internal tremors as well as external essential tremors?
So just like Annette attested to, I believe that the patients do have some type of feeling of tremor in their bodies all over. And that's something that is very dependent on the patient. But it has the ability to help tremor, not just in your hands, but everywhere in your body, especially if we have bilateral stimulation.
Okay. What treatment option would you say works best for tongue and jaw tremor?
So, like I mentioned, we cannot guarantee anything besides hand tremor improvement with focused ultrasound. So we know from experience that using bilateral stimulation, deep brain stimulation, we can control tremor in the center of the body, including head and jaw, and tongue, I guess.
Okay. Annette, I have a question for you. Um, can you talk about what the surgery was like going through that and what the recovery was like from your process? Like, when was you were very recent in your surgery. When was the date of your surgery?
My surgery was actually January 8th or 7th. It was the 8th. I'm trying to remember. So it was this year. It was within the past 12 weeks. I'm going to be honest with you. I was scared. Like I redid my will. I was scared. And then the next day after the surgery, I changed into my bunny pink pajamas and I was so happy. The first let me just see. The day of the surgery was honestly phenomenal. Dr. Fenoy's team and all of the nurses and all of the staff at Northwell they're just so warm and they understand that you're stressed out. And I had my own personal nurse. She kind of held my hand until, I went out of it. When Dr. Fenoy put the helmet or the little Darth Vader thing on me, they even took pictures so I could show my kid. So the experience overall was great. I wasn't scared anymore when I was in the hospital and when everyone was reaffirming this is great, you're doing great, you're gonna be awake. We had a huge team. The next day or when I woke up later that day and I looked at my head because my hair was a lot longer. I recently chopped it off for personal purposes, not for the surgery. But one of my biggest concerns was I going to lose a lot of hair? And the next day I woke up and you couldn't even see where the incisions were. So it was so nice to go home and, wash my hair, put it back, and just nobody knew what happened. Um, I would say right after the first surgery, I had light headaches, and most of that was caused probably by the incisions, like my skin healing, and I took Tylenol. I 2 Tylenols maybe every 6 hours for the first day or two, and that did the trick. The second surgery as a woman was a little bit more difficult because of where they placed this. Um, when you have a chest and you are not wearing your bra, it pulls your skin down. So I just had to wear like really tight sports bra and keep my skin up until it healed better. But that was the most painful of the things if we're talking about pain. Otherwise, the whole experience was honestly great. The worst thing about anything was washing my hair afterwards. Um, just because I had such incredibly long hair, and with the way the incisions were done and the staples, it got really knotted. Um, but that was really the worst of it.
All right, Annette, you're on a roll, so let's stick with another one for you right now. Can you walk through what a programming session is like for you?
Yeah, so programming is weird. I'm not gonna lie. The first time I went to programming session, and they turned it on, Dr. Ramdani worked with my neurologist, movement specialist, worked with the Medtronic rep, um, and they go through how much they can give you in electricity to, and it causes side effects. So some of the side effects that I felt, nothing hurt, by the way. I would say some of the things that happened were facial pulling, which Dr. Fenoy talked about. In particular, I remember the Medtronic rep saying, "Oh, her eyebrow's going up," or you can actually feel some of the muscles in your face contract. Um, and when the intensity was too high and I couldn't tolerate it, I had a feeling of drunkenness is the only way I could explain it, which you tell your people right away, hey, this does not make me feel good, and they pull back. And it was 30 minutes before they got the tremor on my left hand completely under control, and which was amazing. I went back for a second session because the way that they programmed my left hand, they tried using on my right hand and my body just wasn't liking it. So they had to try something different. And even then, my right hand was great. And now the programming that they're using for my right side has zero side effects. When they tried it, didn't have any tingling or anything. The only negative that I would say is that the programming that they're using for the right side is using up a lot more battery. So I went from a 5 year to a 3 year. I think it's like 2 years in some months, but I'm just going to move on to a rechargeable one. So we have a game plan going forward. So yeah.
Okay, awesome. Annette, you're a hit. So this could be really anxiety provoking for people. Like when they hear that they have to be awake for part of surgery, right? Can you describe, Annette, what it was like when you were woken up and had to participate in some of these neurological assessments, coming out of anesthesia, doing the tests, and then going back under?
Um, I heard I was fun. I remember some of it. Um, so while I was awake, first of all, the anesthesiologists are phenomenal because I was not stressed out at all. So whatever they gave me was great. I remember Dr. Fenoy asking me to repeat a very specific sentence. I don't remember what that sentence was, but clearly it was to see how my speech was doing. And they checked to see the tremor on my hands and if I was having any tingling or any negative side effects. So I was awake for obviously that, but to be honest with you, I don't remember a lot of it. It was not traumatic at all, or scary whatsoever.
Okay, awesome. These are more specific questions, but maybe they can help somebody else that's listening. Um, Somebody has trunk tremor and hand tremor, as well as orthostatic tremor. Would deep brain stimulation or focused ultrasound work better for them?
I would tend to think that deep brain stimulation would, if they want to address all of the tremor. Again, if they want to just address their hand tremor, we would give them both options, and either one would work.
Okay. Another participant has a conversion disorder, which manifests as seizures in all types. They're under control due to therapy, but is that a contraindication for focused ultrasound therapy?
I would say if there's no structural abnormality in their brain, then or like a lesion that's causing that, then it should not be, as long as the seizures are controlled.
Okay. Annette, yeah, you live in New Jersey. I know New Jersey is a big state, although I'm not great at geography. But who do you mind sharing who your neurologist in New Jersey was?
So I'm not going to tell you who my neurologist was because he left a distaste in my mouth. What I will tell you is that I am currently under the medical care of Dr. Fenoy and his team. So I do travel to Long Island. It's just such a great experience. I don't care, and I work from home all the time, so it works out for me. However, in a few months, when my programming is completely set, I've already talked to some of the Medtronic reps, and they have found me a more local programmer or neurologist, movement specialist in the area, so that I will still continue to see Dr. Fenoy in a few months. He is my neurosurgeon. For follow-ups and, just how everything's going. But I will eventually, when I'm settled into the correct programming, have a programmer. I believe they found me someone in Morristown. There's also people in Hackettstown. I live in Sussex County, which is a little bit in the woods by the cows. So no matter what, I have to travel a little bit, but there's Medtronic neurologists around. So.
Okay, awesome. Dr. Fenoy, if a patient has focused ultrasound, can they then at a later time have deep brain stimulation?
What an interesting question, Kristen. Yes, they can. However, we would probably want to advise a patient that if they are thinking about deep brain stimulation at the get-go, we would do that first. So if we treat a patient with focused ultrasound, we are creating a lesion. We are destroying brain tissue. Even if a tremor comes back, that tissue is somehow perturbed. It is not native, untouched tissue. I have put electrodes into a patient post-focused ultrasound, and the efficacy or how well they do is not the same as a patient who has never had focused ultrasound. So what I'm trying to say is that if you want deep brain stimulation, do that at the get-go. Don't do it as a technique. Well, I'm going to try focused ultrasound first and then do deep brain stimulation because it doesn't work as well. It certainly can be a salvage operation, but don't think of it that way.
You touched on the shaving of the head for focused ultrasound. But why does the whole head need to be shaved? Why not just in the area that you're treating? Like if you're treating.
Yep, it's a good question. So we have this helmet shaped transducer that goes all like it's a hemisphere that goes over your skull, and up to 1024 elements can be used. The more elements we have, they all can be used to converge to the target we're trying to blow up, the size of a pea. So if we have less of them, we can't create this lesion. So if there's hair, like we talked, that factors in, just like that skull density ratio, it factors in, it'll refract, or the ultrasound beams will not be able to be focused through. So we need all of the skull to have as many elements as possible to increase the firepower necessary to nuke the target.
All right. Do either of you, Dr. Fenoy or Annette, have anything else you're dying to share?
No, I just want to, again, thank you so much for participating. And I thank Annette so much for giving up her valuable time to share with us her story. So thank you so much.
Yes, thank you all again for attending tonight. Thank you, Dr. Fenoy, for your presentation. Thank you, Annette, for choosing Team Fenoy and allowing us to participate in your care. If anyone has any further questions or wants to discuss their individual circumstances or treatment options, please contact our office. You can use either 516-550-2100. To schedule a consult. If you'd like more information about either treatment option, focused ultrasound or deep brain stimulation, Dr. Fenoy created that awesome website, www.albertfenoymd.com. You could see pictures, read a lot of information, look at media articles and his social media page. But thank you all, and we hope you have a great night.
Take care. Bye-bye.
Have a good night.